Hi, today we are going to discuss cognitive impairments associated with schizophrenia. This is an educational program that was put together by the France Foundation. It involved Dr. Daniel Javitt and me. I am Deepak Cyril D'Souza, professor of psychiatry at Yale University School of Medicine. I direct the schizophrenia neuropharmacology research group at Yale, and I have been working with patients with schizophrenia for the last 30 or more years.
I'm Daniel Javitt. I'm a professor of psychiatry at Columbia University and also director of schizophrenia research at the Nathan Klein Institute for Psychiatric Research in Orangeburg, New York. Like Cyril, I've been working on schizophrenia for over 30 years at this point, especially focusing on brain mechanisms underlying cognitive impairments and negative symptoms, and especially looking at the interplay between glutamate and dopamine systems, which of course are becoming increasingly important as new drugs enter the pipeline.
So, the learning objectives for today's program include having you all recognize the heavy burden of disease and the ongoing unmet needs in patients with cognitive impairments associated with schizophrenia. We want you to better differentiate cognitive impairments from negative symptoms through improved recognition of the clinical features and pathophysiology of cognitive impairments. And then we want to discuss ongoing developments in clinical research and improved perspectives on care pathways that may help address some of the current limitations in the clinical management of the cognitive impairments associated with schizophrenia. Without further ado, I'm going to present a case to you, and we're going to use this case to meet some of these learning objectives. So George is a 20-year-old single male. He had his first psychotic break about 2 years ago when he was in his first year of college. His symptoms, for the most part, stabilized with treatment on a second-generation antipsychotic. His positive symptoms seemed well controlled. He continued to have some odd thoughts. He tried returning to school, but unfortunately was unable to keep up with assignments. And so he returned to live at home with his parents. He attends outpatient treatment twice a week. He has an interesting routine that I'll talk about. He wakes up at 10 a.m., he watches TV, then has a meal. He says he hangs out and watches more TV. He's not working, he's not going out, he's not socializing with any of his friends. He doesn't go out except for his outpatient appointments twice a week. He generally keeps to himself. He used to enjoy reading books and no longer is able to read books or play chess. So, Dan, I'm going to call on your expertise and ask you to maybe talk about what signs and symptoms you think this patient is exhibiting, how the patient might talk about these symptoms, and perhaps if you can touch on how to differentiate some of these symptoms.
So, Cyril, thanks for including me in this. And I think the case you chose is very explanatory, is a very typical case that people will encounter. Somebody who, after developing the illness, loses interest in going back to school and work. And that is one of the main burdens of schizophrenia. The negative symptoms, the lack of interest in resuming activities. And also, I think you bring up 2 points about his cognitive abilities. One part of cognition, of course, is just being able to do coursework in school and cognitive tests. But another important part of cognition is what's called social cognition, the ability to interact with other people. So I think you talked very nicely about his lack of interest in interacting with others.
Yeah, so I wanted to add to that, Dan, that you know, while some of his symptoms seem to be well controlled, I want to be specific about what those symptoms are. Those were positive symptoms that seem to be well controlled. But despite those positive symptoms being well controlled, he is not able to go back to what he was previously doing, which was he was going to school. And so it highlights how Other symptom domains like positive and negative symptoms and cognitive deficits can contribute to to uh, the challenges in recovering from a psychotic episode. So, what is the burden of disease and unmet needs in patients who have cognitive impairments associated with schizophrenia? This impacts their quality of life, substance use, mortality. There are some of the medications that we use to treat schizophrenia have side effects that might impair cognition and may actually induce secondary cognitive deficits and secondary negative symptoms. We also know that in schizophrenia, there is some activity dependent plasticity dysfunction, meaning to say that we think about the brain as an extremely plastic organ. The brain has an incredible capacity to learn. Unfortunately, in schizophrenia, there may be some fundamental deficits in this learning process and plasticity. We also want to spend some time talking about specific side effects of medication that might further impact cognition. And I'm referring to, in this case, anticholinergic side effects. There's some antipsychotic drugs that are more likely to cause anticholinergic effects than others. And then, as you know, many clinicians also use anticholinergic drugs to treat some of the motor side effects of dopamine 2 antagonists. So, some facts about cognitive impairments in schizophrenia. We think of cognitive impairments as a core symptom domain in schizophrenia. It used to be the case until the 1970s and 80s that schizophrenia was mainly thought to be a disorder of positive symptoms, and then we became aware of negative symptoms. And now we are aware that cognitive symptoms represent a core symptom domain in schizophrenia. These are present in the majority of patients. They significantly impact a patient's functioning. Unfortunately, we don't have any quick bedside tests to measure cognitive impairments in schizophrenia. And most of the test batteries that are out there would be difficult to implement in a typical half-hour or 1-hour session with the patient. And as I mentioned earlier, patients and their families rarely ever complain specifically about cognitive impairments because they're not familiar with them. And clinicians rarely have cognitive impairments on their radar and therefore rarely ask about those. But there are ways of measuring cognition, which we will talk about. And some of them include paper and pencil tests, which is a traditional way cognitive impairments are measured. And more recently, there's an array of cognitive batteries that are computer-based that can be used to measure cognitive impairment. This is a graph showing data from the matrix consensus cognitive battery in patients with schizophrenia. In general, if we take a composite measure of all the cognitive processes, which are described here, which include processing speed, attention, working memory, verbal memory, visual learning, abstract reasoning, and social cognition. If you put all of them together and come up with a composite score, patients with schizophrenia score about 1 to 1.5 standard deviations lower than age-matched controls. As you can see, all these domains of cognitive function are impaired, including processing speed, attention, working memory, verbal and visual learning, abstract reasoning, and social cognition. And these are all within the 1 to 1.5 standard deviation range. But you should know that the range was 1 to 2.5 standard deviations in some of the studies. And that's because some of those studies included patients who were quite severe in their illness and therefore had scores that were much greater, or they showed greater impairments. We think, though, that the usual range is somewhere between 1 and 1.5 standard deviations lower than controls. So you'll hear more about this. There are other domains of neurocognition, which these are neurocognitive domains that are really the building blocks of cognitive processes. And these include sensory processing. So that is the ability to detect changes in our environment, both in what we hear and what we see. Motor processing abnormalities, which could impact our ability to perform complex motor tasks. And neuroplasticity, as I mentioned earlier, the brain's capacity to learn and change, which we think may be fundamentally impaired in schizophrenia. So some examples of this include deficits in auditory processing, and this would be measured by testing how able a person is to match tones following a delay, and how this might impact cognition would be it would make it harder for us to understand nuances in the tone of someone's voice, in detecting sarcasm, in detecting emotion. The way this might impact our visual processing is it may make it difficult for us to process, say, facial expressions, to know that someone is upset with us or that someone is happy or sad. And a motor processing, this could impact how quickly we are able to perform complex motor tasks. Okay, let's move on to the next set of questions. So, this is a figure that shows the temporal course of the different symptom domains of schizophrenia: positive symptoms, negative symptoms, and cognitive symptoms. You can see the positive symptoms shown in red. These are the ones that are most obvious to us as clinicians, as family members, and others in trying to determine when the first psychotic episode occurs. And you can see that the cognitive symptoms and the negative symptoms, shown in blue and green respectively, appear before the onset of the first positive symptoms. So this is really important, and this further speaks to the idea that cognitive symptoms and negative symptoms represent core symptom domains in schizophrenia. So these are established years before the onset of psychosis and may reflect loss of tissue and function in those brain areas that subserve these cognitive processes. There may be some accelerated loss of cognition during the prodrome. Most of the deterioration in cognitive function occurs within the first 5 to 10 years of the onset of the illness. As I mentioned earlier, cognitive deficits are robust, between 1 and 1.5 standard deviations from the normal. First episode in chronic patients don't seem to have that many differences in their cognitive functioning, suggesting that, and this is specific for verbal memory and learning, this would suggest that the cognitive deficits are already present at the first episode, and chronicity is not necessary for these cognitive deficits to occur. We're going to spend some time talking about the differentiating cognitive symptoms from negative symptoms. We're also going to talk about differentiating primary and secondary cognitive symptoms. And Dr. Javit is going to talk about that later on in this presentation. As I mentioned, most of the cognitive deterioration occurs within the first few years of illness, and these cognitive symptoms appear to be enduring. That is to say, while positive symptoms can wax and wane with every episode of psychosis, these cognitive symptoms seem to be relatively stable, with the exception of maybe secondary cognitive symptoms. The available studies on the premorbid phase of schizophrenia would suggest that both general and specific cognitive impairment, including IQ, attention, memory, reasoning, and executive function deficits, and processing speed, are already present then. Now, in clinically high-risk individuals, they too show worse executive function, attention, general level of intelligence, processing speed, verbal fluency, visual, verbal memory, and working memory. So, interestingly, those who convert to psychosis show worse cognitive test performance compared to those clinically high-risk individuals who do not convert, suggesting that cognitive dysfunction may be a marker of who is going to transition into full-blown schizophrenia. I want to draw your attention to the concept of social cognition. Social cognition refers to those processes that facilitate our engagement with the environment, meaning to say our engagement with the people around us. And there are some key components to social cognition. This includes the specific auditory and visual emotion recognition processes, which help us connect with people, help us understand when someone's angry with us, help us understand sarcasm in someone's voice, and so on and so forth. These may be mediated by some of the specific neurocognitive processes that we talked about earlier, including very early sensory processing. So how do these cognitive impairments that may have seemed somewhat theoretical to you impact a person's everyday life? Well, there is convincing data that these cognitive impairments there's a direct correlation between the level of cognitive impairments and real world functioning. That is, whether a person is able to go to school or not able to go to school, like our patient George. And we know that the cost of schizophrenia, as you know, in this country runs into the billions of dollars. Some of that is related to the direct costs of medications, clinical care, hospitalization, and so on and so forth. And then indirect costs, which are substantial. And those indirect costs are related to the fact that 80 to 90% of our patients remain unemployed for most of their life. And so they become wards of the state, and the state has to provide for them. That's an incredible cost. And even in those patients who are able to work, cognitive impairments are associated with lower wages, fewer hours of employment, and fewer benefits. And going back to our patient George, one could argue that cognitive impairments are what are interfering with his capacity to go back to school. So how might we measure cognitive impairments in schizophrenia? One bedside test that could be used is the digit symbol substitution test. And in this test, it involves a key with numbers 1 to 9. Each is paired with a unique symbol or punctuation mark, and a series of numbers in random order that are below the key. The test taker has to copy the symbols into the spaces under the number. And this is usually done within a time frame of 90 to 120 seconds. And the score of this test is generated by the number of correct matches made within the specified time limit, which I said was somewhere between 90 and 120 seconds. So just to give you a perspective of the degree of impairment in schizophrenia, the cognitive impairments in schizophrenia, one way of thinking about it is that, if you recall, I mentioned that the average cognitive impairments in schizophrenia range from between 1 to 1.5 standard deviations. So that would equate to being deprived of sleep for a full night. That's how you might perform on cognitive tests. If you've been kept up all night and you're asked to take a cognitive test, the kinds of tests that I mentioned earlier, that's the degree of impairment that one would see in schizophrenia. Lastly, I'm going to talk about how we might be able to measure the impact of cognitive impairment in people with schizophrenia. In the past, we used to use a global assessment of functioning, and now we are using the WHODAS, which is developed by the World Health Organization to assess disability. For each item, it's scored from 1, that's none, to 5, which is extreme. And there are some cognitive items, including concentrating or doing something for 10 minutes. As I mentioned to you, our patient George was unable to read or was no longer reading or playing chess, which is something he used to like doing in the past. Remembering to do important things like keeping clinic appointments, analyzing and finding solutions to problems in daily life, learning a new task like learning music, or, for example, learning how to get from your home to the clinic. Generally trying to understand what people are saying and being able to start and maintain a conversation. The mean score in schizophrenia is roughly around 25. Now I'm going to hand over to my colleague, Dr. Javed, who is going to spend time discussing how to differentiate cognitive impairments from negative symptoms, and then speak about these existing approaches to treating cognitive impairments and the treatments that are currently in development. Dr. Javed?
Thank you, Dr. D'Souza, for that introduction. In this next section, we'll be talking about differentiating cognitive impairments from negative symptoms of schizophrenia. While we're thinking about that, I'd like to show you this slide, which illustrates some of the links between cognitive impairment associated with schizophrenia, again abbreviated as CIAS, negative symptoms, and outcome. And this was a study of 1,400 some odd patients with schizophrenia, where they were assessed both on negative symptoms and cognition. And their negative symptoms were characterized both as expressive negative symptoms, which are features such as blunted affect and alogia, which is reduced speech, and experiential negative symptoms, which are features such as avolition, anhedonia, or asociality. And what this chart shows is, first of all, that both cognition and experiential negative symptoms especially contribute to functional outcome. So if you think about functional outcome,
as the ability to return to work or school, to live independently, to hold a job, to have friends, both the impairment in cognition, which, as you've heard, is maybe 1.5 standard deviations in severity, and also the experiential negative symptoms contribute to those functional impairments. What this slide also shows is that the cognitive impairments in schizophrenia are quite widespread. They not only affect things like memory and executive functioning, but they affect basic sensory functions, auditory functions, visual functions, even early auditory information processing, such as the ability to match tones following brief delay or being able to interpret tone of voice. And those deficits cascade up the system to affect functional outcome, meaning that if you want to try to intervene, you have to intervene at the lowest levels that patients are showing deficits. So now we'll go back to the case of George. And to recap, George is a 20-year-old male. 2 years ago, he had a first psychotic break during freshman year in college. His symptoms have now stabilized. His positive symptoms are reasonably well controlled, although he still has some odd thoughts. But about 6 months ago, he tried returning to school and he was unable to keep up with assignments. Currently, he lives with his parents and he attends outpatient treatment 2 times per week. So where George is now is he's trying to decide, should he return to school, should he get a job, or should he remain in his present treatment setting?
So where George is now is he's trying to decide, should he return to school, should he get a job, or should he remain in his present treatment setting? So Cyril, what are your thoughts on?
So Dan, I think this is an excellent illustration of cognitive symptoms and cognitive impairments and negative symptoms, and how might we differentiate between the two. So he's having trouble, or he doesn't seem to have any interest in going out with his friends, which is something he used to do before. He has no interest in reading or playing chess. These could fall under the domain of negative symptoms, as in lack of motivation and anhedonia, but they could also be cognitive impairments, because maybe he's not able to concentrate on reading a book for long enough periods of time, and that's frustrating. And likewise, he may have problems with planning and execution. That's why he's not able to play chess, which is something he used to do before. And all that might also contribute to why he's struggling with whether he should go back to school or whether he should stay at home, and whether he should get a job or stay in this clinic. So I'd be interested in hearing from you if there are other things that you might think of as you differentiate cognitive and negative symptoms. And would you agree that often you can have cognitive symptoms and negative symptoms in the same patient?
Right, and I think what you said is absolutely correct, that this person could have both negative symptoms and cognitive symptoms. And I think one thing that's important as clinicians is for us to explain to families, both the patients but especially families, that when someone's not returning to work, it's not that they're choosing it. It's that this is now part of who they are, that these are symptoms of an illness, that these are not choices the person is necessarily making. And also, in terms of the cognition, it's important to explain to families that what the person was able to do before they developed the illness in terms of cognitive function, in terms of work or educational expectations, might not be reasonable at this point.
I wanted to add about this issue of how would patients and family members talk about this. So clearly, patients and family members are not going to say, I have trouble with my verbal memory or my visual learning or my abstract reasoning. That's not what they're going to say. What they're probably more likely going to say to you is that, you know what, he can't read the newspapers, or he's having trouble filling out these application forms to go back to school, or he's having trouble, reconciling his checkbook or his bank account. Those are the ways that patients might and their family members might draw attention to cognitive impairments. And that's where you as a clinician need to recognize that, okay, what they're talking about is maybe attentional problems, what they're talking about may be memory problems, and help educate your patients about some of these symptoms. So the kinds of questions that you could ask as a clinician um, would be exactly the kinds of things that I mentioned earlier. How long can you hold a conversation with the patient? You can ask the family member about that. Uh, how long can the person say watch their favorite TV show without getting distracted? Or when you send them to the grocery store to buy a list of things, do they forget what they were sent there, or they come back with an incomplete list, or are they able to remember when to pay their bills? These are all, um, you know, processes that could be impacted by cognitive impairments. Dan, do you want to add anything to that?
No, I think you have hit the nail on the head with this. That it's just important for people to understand that this is the illness and it's not something the person has control over, and that intervening, trying to come up with specific remediation programs or psychoeducational programs might help uh, people cope better with the new situation that they find themselves in.
So going back to our case study, let's talk more about the differential diagnosis between cognitive impairment and negative symptoms. So both cognitive impairment and negative symptoms could contribute to George's inability to return to college. Cognitive impairment is the reduction in cognitive abilities that patients with schizophrenia experience during the early years of their illness, or even during the years preceding illness onset. They may, in fact, precede the illness by even 3 or 4 years. And they lead to an inability to process the necessary information to succeed in school or work. And an important feature, of course, is that patients, as they go through the illness, have a decline in cognitive function. So things that they were able to do before they had their first episode of the illness, they may no longer be able to do. If they were functioning at a higher level in school, when they go back to review their course materials, they may no longer be able to understand it or process the information as efficiently and successfully as they were before. And it's very frustrating to the patients, very frustrating to the family. It's often attributed to lack of willpower, to lack of motivation. But in fact, if you do specific cognitive testing, you realize that patients have lost the ability. And it's important over the course of the illness to reset expectations so that you no longer expect people to do what they're no longer capable of doing. So, for example, if they try to go back to the courses they had, try to look over their course materials, can no longer process those materials. It's important to help them understand that it's not that they're not trying, but that they just don't have the systems working anymore that would allow them to process that information. So in this case study, let's go even further in differentiating cognitive impairment from negative symptoms. On interview, George describes the following. Although he feels happy when he gets a good score on a test, he does not think that studying for a test will be worth it, even if he succeeds. He used to enjoy playing on an intramural flag football team, but he is no longer interested in being involved. And before the illness, he had a steady girlfriend and was sexually active. However, at present, he has little interest in either having a girlfriend or in sexual activity. And these, of course, are all features that one can think of as negative symptoms. So the question is, given the importance of cognitive impairment as a feature of schizophrenia and as a contributor to poor outcome, what can we do about it? And one of the unfortunate features is that none of the medications we have is especially successful at treating cognitive impairments. So these are figures drawn from the Katie study, which was a large naturalistic study of the effects of both typical and atypical antipsychotic agents. And as part of it, they looked at neurocognitive function, neurocognitive composite scores, both after 2 months of treatment and after 18 months of treatment. And the good news is that there is some improvement in cognition on most of the compounds, but the bad news is that it's very small and not enough to really make a dent in the severity of cognitive impairment that becomes apparent in the course of schizophrenia. One aspect of treatment that we can control is something called anticholinergic burden. So, of course, the important features in medicine is first, do no harm. And unfortunately, some of the medications that we need to use as part of the management of schizophrenia can negatively impact cognition, and especially compounds that have a strong anticholinergic burden that block acetylcholine receptors. And these compounds are used to prevent motor side effects of dopaminergic agents, but unfortunately they contribute to cognitive impairment. And not only that, but specific antipsychotics have high levels of intrinsic anticholinergic activity. They were designed that way to make them have reduced motor side effects, but it does contribute to the anticholinergic burden. And also antidepressants, which are commonly used as add-on agents, as adjunctive agents in schizophrenia, may also have anticholinergic effects. So one way to quantify anticholinergic burden is to think of it on a scale where compounds are rated 1, 2, or 3 based upon their anticholinergic burden. And on this slide, we have a list of compounds that have a high rating for anticholinergic burden. In this case, they would give a 3 on the anticholinergic burden score. So these are things like the anticholinergic agents that are used to control motor side effects, but also some second-generation antipsychotics, especially olanzapine, quetiapine, clozapine, some first-generation antipsychotics, especially the lower potency agents, and some antidepressants that you might use. And on the right, we're showing you the negative consequences of anticholinergic burden. And the scale goes from blue, which is 0 anticholinergic burden, to purple, which is very high, an anticholinergic burden of greater than 6. And what is being shown is the cognition score across a number of domains that you've heard about before, things like attention, working memory. And so when you get to scores that are high, scores that are 5 or 6, you may be having negative effects on cognition. The good news is that if you have relatively low anticholinergic burden, say a score of even up to 2 or 3 on this scale, you don't have much effect. It's really combinations of medications that have anticholinergic burden that will most impair cognition. So one thing as a clinician you can do is to make sure you go through the person's medication and make sure that they haven't ended up on a combination of drugs that, even though they're controlling symptoms, have high levels of anticholinergic burden. So to illustrate this point, we'll give you a case study for treatment. And now we'll go back to George, whose goals are to return to school or get a job or move out of his parents' house, and his medication. And this is very typical of individuals with schizophrenia, that they'll end up on multiple medications to try to address different features of their disorder. So he started on long-acting risperidone, but he required an anticholinergic medication, in this case benztropine, to treat the motor side effects. He was also given antihistamine at bedtime due to difficulty sleeping, which is also a common feature of schizophrenia. And since he had what might have been depressive symptoms, he was given antidepressant and a mood stabilizer to address the potential depression issues. In terms of response to that treatment, his positive symptoms are now stable on medication. So in that case, you would consider this a success. But he lives in a group home, attends a day program, reports some daytime sedation, although otherwise he says he's doing okay, but tells you he has trouble concentrating, has dry mouth, and constipation. In terms of overarching features, he still shows little motivation to return to school or find employment. When asked, he says that looking for a job is not worth it, and he feels that school would be too difficult. 1, would you want to increase his antidepressant dose? And here, of course, adding medication could increase the anticholinergic burden. Plus, we don't have strong support that any of his ongoing symptoms are from depression. We could switch to an oral antipsychotic, but in fact, that would not only probably make management more difficult, it might also get rid of some of the control that we have. We have good control of positive symptoms with the long-acting injectable. So to go back to an oral antipsychotic without really good reason is a step in the wrong direction. Reduce the anticholinergic burden, and that's something we should certainly consider. And there, again, the antidepressants were added because of potential depression, but in retrospect, they may not have been beneficial. It's always important when adding a drug to the cocktail of medications that a patient is on that you monitor carefully and you decide if, in fact, it was effective, and if it wasn't effective, to take them back off. So in this case, reducing the antidepressants could reduce the anticholinergic burden. It could even be that the medications for side effects, for motor side effects, could be reduced. And it could be that the sleeping medication isn't needed, or that he could be given something to help with sleep that doesn't have a high anticholinergic burden. Should you add a long-acting benzodiazepine? Again, right now, none of the symptoms that he has seem to be related to symptoms that might be controlled by a long-acting benzodiazepine, things like anxiety or panic disturbance. You might consider using a short-acting benzodiazepine to help with sleep instead of the antihistamine for the purpose of reducing anticholinergic burden, or you might, if the sleep medication is not helping, remove it altogether. So in this next section, we'll talk about current management recommendations and ongoing clinical research. So one treatment you might consider is cognitive remediation, which may be beneficial in schizophrenia. So this is talking about results from a recent meta-analysis of 130 studies of cognitive remediation involving 8,851 patients, so a large database. Cognitive remediation has been used widely in research, although it's not currently a mainstay of practice. The effect size of cognitive remediation right now is in the range of 0.2 to 0.3, which is relatively small, but the field is continuing to make progress and coming up with approaches that are increasingly efficacious, meaning that even if it's not part of treatment now, it may well be within the next coming years. And one of the results of the meta-analysis is helping choose the optimal candidates for cognitive remediation, people with fewer years of education, lower premorbid IQ, or higher baseline severity. And of course, when you do cognitive remediation, there are crucial elements that have to be included, things like having an active and trained therapist. You can't just put a patient in front of a computer screen with computer exercises and expect them to go through it on their own and benefit from it. You need a person who's not only there giving them encouragement, but also helping them understand how they can apply that to their daily living. You need a structured development of cognitive strategies, and especially you have to rebuild from the bottom up. So if somebody's having deficits in basic auditory processing, such as the ability to match tones, you have to restore those abilities before you can possibly hope to teach them to use those abilities, for example, to understand tone of voice, happiness, sadness, sarcasm. And you have to integrate this with psychosocial rehabilitation. Giving people skills by itself isn't enough. You have to have them practice using it in real-world settings so they can get comfortable using it in their day-to-day function. Another intervention that can be done and seems to be beneficial even now is aerobic exercise. Improves cognitive function. And of course, it's well known that it improves cognitive functioning in everybody, but it may be especially important in schizophrenia, where as part of the illness, the negative symptoms tend to reduce physical activity. So you need to encourage and structure aerobic exercise. And if you do, one can see significant effects on things like global cognition, working memory, social cognition, attention vigilance, many features of schizophrenia. There are some things that may not improve, but overall, there are, of course, no side effects to aerobic exercise, and obesity, hypertension are all serious medical conditions that affect schizophrenia. Another aspect of the illness that clinicians may not be paying enough attention to. So encouraging aerobic exercise and even building in a program for aerobic exercise will both improve physical well-being and improve cognitive function. So the question is, what does cause the negative symptoms and cognitive impairments associated with schizophrenia? What are our current mechanistic theories? And what we know is that it's not confined to a single brain region. So there's no one region that if you have a stroke or injury, you will end up showing symptoms that recreate the entire features of schizophrenia. It's not adequately explained by dopamine models of schizophrenia. If you give a drug such as amphetamine, which increases dopamine levels in the brain, it doesn't reproduce the symptoms. And if you give medications that block dopamine receptors, like all of our current antipsychotics, they don't meaningfully improve cognition. What we do know is that they can be reproduced by ketamine and other compounds that block NMDA receptors. And here I'm showing you work that was actually done by Dr. D'Souza in his early days. And this is looking at the relative effects of amphetamine, which is a dopamine drug, and ketamine, which is an NMDA antagonist, on cognition, in this case, verbal learning, your ability to learn new material. You're given a list of words, and the question is, how many can you retain, both immediately and then after a delay period? And patients have severe deficits in this. It's one of the matrix domains. So if you have somebody and give them placebo, they can learn maybe 10 words if you read the list of them several times. If you give them amphetamine, it doesn't really change their behavior. If you give them ketamine, which is that bottom line, it reduces their behavior almost in half. And that's the level of deficit that one might see in schizophrenia. And then if you combine that with amphetamine, it doesn't impair it more. In fact, it may even improve it a little bit. So the only compound in that list that really reproduces the cognitive impairment is ketamine, which is the NMDA antagonist. And you can see the same thing with different NMDA antagonists and also with different types of cognitive tests. So that's the best mechanistic theory for right now for what's causing the cognitive impairments. But it's also true that if you give antimuscarinic compounds, they can further impair cognition, as we talked about, by inducing cholinergic burden. And that mechanistic theory of schizophrenia focusing on glutamate and NMDA receptors is also supported by recent analysis of studies focusing on cognitive impairment in schizophrenia. And here they looked at multiple studies across multiple types of neurotransmitter systems. And of all the systems listed, only glutamate, which was used in 17 studies, often with compounds such as glycine or D-serine that targeted the modulatory side of the NMDA receptors, but also with other compounds. So across all of those studies, there was a significant effect on cognition, not a large effect size, but enough to suggest that maybe more effective treatments might lead to even further enhancements in cognition. So these are the therapies that are in the pipeline for cognitive impairment associated with schizophrenia, and they work on a range of mechanisms, although many of them converge on the glutamate and NMDA receptor site. So one of them is a compound, icolpertin, also called iclopertin, which works by blocking glycine transporters. And by blocking the glycine transporter, and we'll show you this in just a little bit, it increases glycine levels in the synapse, which increases NMDA receptor function. It's being developed right now for cognition in schizophrenia, for CIAS. It's currently in phase 3. It was originally thought that those studies would report out in early 2025, but there's some thought that they may even report out in late 2024. This has been through a phase 2 study, which I'll show you in just a little bit, that showed encouraging results and showed significant benefit. A second compound is called luvadaxistat, which is, again, an oral agent, and it blocks something called the D-amino acid oxidase enzyme, which breaks down D-serine in the brain. So by breaking down D-serine, we can increase D-serine levels. This is also being developed for cognitive impairment associated with schizophrenia as an adjunctive to antipsychotic agents. It's currently in phase 2. And there's several other compounds in phase 2. CY6463 works by targeting nitric oxide signaling, which may be downstream of NMDA receptors. CVL562 is a dopamine D1 partial agonist. Dopamine has been somewhat implicated in cognition, but also interacts with NMDA receptors. And RL007 works at multiple sites. Also GABA B, which mediates inhibitory responses, NMDA receptors, and also nicotinicholinergic receptors. And that's also being developed for CAIAS and also in phase 2. One of the background findings that's led to the emerging treatment target on NMDA receptors are positive studies with glycine and D-serine, which are endogenous amino acids that modulate NMDA receptors. They've been used in several small-scale studies, and they've been shown as add-on to antipsychotics to improve both negative symptoms and cognitive impairments in schizophrenia. Unfortunately, they're difficult to administer on their own. They need to be administered at high doses. They're not FDA approved, and they're more ways of testing the theory than practical treatments for schizophrenia. The new drugs work by affecting glycine and D-serine levels, not by changing the amount of glycine and D-serine that enter the brain, the way you might do if you gave large doses of the amino acids themselves, but they work on the systems that normally eliminate glycine and D-serine from the brain. So this is an illustration of how the different compounds may be working to try to enhance NMDA receptor function or cognitive function overall. So the first compound I want to highlight is icolpertin. Icolpertin blocks the glycine type 1 or GLYT1 transporter that normally takes glycine out of the synaptic cleft and transports it to the astrocyte. That's the normal way by which glycine levels are regulated in the synapse. So by blocking the GLYT1 transporter, icolpertin leads to an increase in glycine levels both in the brain and in the synapse. A second compound is luvadaxistat. Luvadaxistat works on the enzyme D-amino acid oxidase, which is the enzyme that breaks down D-serine. So in the case of luvadaxistat, blocking DAAO will increase D-serine levels in the brain and in the synapse, and that also will lead to enhancement of NMDA receptor function. So those are compounds that are working directly on the NMDA receptor by changing the amino acid levels of the amino acids that are modulating the NMDA receptor function. So this is a closer look at the phase 2 data from icolpertin, which is a glycine transport inhibitor. These data are from 2021, and these show the effects of increasing doses of icolpertin, which is at the time called BI 425809, across multiple doses, 2, 5, 10, and 25 milligrams. And on the left panels, you can see that as one increases the dose, the degree of cognitive improvement increases so that one gets significant benefit at the higher doses at 10 and 25 milligrams. And on the right, you can see that the cognitive improvement is progressive over the course of the study from week 6 to week 12. So even though, and it was significant at week 12, but the trajectory of the curve holds the hope that if the studies were continued for longer, that the benefit might be even more pronounced. And of course, nobody expects cognitive impairments in schizophrenia to magically resolve with any medication. The person has experienced an insult, the same thing as if you didn't use a muscle for weeks or months or even years. Even if one were given an intervention that allowed the muscle to start working, it would have to be rebuilt. And this feeling is the same way in cognition, that these medications will be the beginning of the rebuilding process, but will not be a magic drug where you take them and the next day you're totally better. In terms of what helped predict better response in this data set, having lower antipsychotic levels, so less D2 and less cholinergic burden, possibly allows these treatments to work better. Having more negative symptoms, which may indicate that these are patients for whom NMDA receptor mechanisms are especially important, and patients who are not receiving benzodiazepines, which can impair the excitatory inhibitory balance and may prevent the benefit of the drugs from becoming apparent. There was also better response in younger people who, of course, have had the cognitive impairments for a shorter level of time. For those with most pronounced cognitive impairments, where you know that the cognitive impairments are most likely due to the illness, and for those who have had a shorter duration of treatment, and again, younger, more plasticity in the brain, and less lingering effects from the cognition impairments that have been present. There are other compounds presently in development for the treatment of schizophrenia. One treatment that's very exciting from an overall perspective is a medication called KarXT, which is a combination of xanomeline and trospium for psychosis. It works by targeting the muscarinic system with essentially acting agonist and a peripheral antagonist to try to reverse side effects or prevent side effects from the agonist, things like nausea and dry mouth. And this is a study where the positive symptoms improved very significantly to the same level that one might see with antipsychotics. It's a compound that's currently being considered for approval by the FDA and likely will be improved and will give another option for treating positive symptoms of schizophrenia. But despite the improvement in positive symptoms, the improvement in negative symptoms was quite modest, was significant at only one time point, and was not large. And this again shows us what we're up against with our current medications. They're effective for the treatment of positive symptoms, but not especially effective for the treatment of negative symptoms or of cognitive impairments. Although cognition was not the primary target of the KarXT studies, they did include cognitive batteries as part of the studies and did post hoc analyses looking at change in cognition. And in both studies, they found that in the full sample, there wasn't a beneficial effect on cognition. In terms of numeric, it was quite modest. It was in the range of 0.1. And in terms of significance, it wasn't close to significant. When they looked at about a third of the patients with the most severe cognitive impairments at baseline, they did show a beneficial effect on cognition with an effect size of about 0.5, which would be clinically noticeable and a significant p-value. But of course, this is a post hoc analysis and needs to be replicated in a study where this is the primary endpoint. But if it can be replicated, it possibly gives another way forward for the treatment of cognitive impairment, at least in a subset of individuals.
So, Cyril, what are your thoughts about how these new treatments that are coming to clinic might affect the management of both negative symptoms and cognition?
So that's a really important question. I think it's an exciting time. Exciting because, as you have reviewed so far, Dan, the existing treatments that we have, the available antipsychotic drugs, and attempts to augment the antipsychotic drugs with other drugs have really not yielded significant effects on cognitive impairments. But now we have a situation where there are several drugs that are in development that are specifically being developed to target cognitive impairments. And if we look at some of the preliminary results of some of the published studies, there's reason for us to be hopeful that we may have a new class of drugs in the pipeline that would be used in combination with dopamine 2 antagonists in managing the various symptom domains of schizophrenia. I think particularly interesting is that I know you have done work in this space for a long time on NMDA and glutamate receptor function and schizophrenia. The fact that these studies have a very strong mechanistic rationale is also quite interesting to me, and I'm really hopeful that in the next year or two we may have more information about the efficacy and safety of these drugs to open a new kind of era in the development of in the treatment of a cognitive symptoms of schizophrenia.
Right. And I think what you point out is that we do have good models that potentially explain how the negative symptoms and cognitive impairments arise. That if you give ketamine to a healthy volunteer, they will show negative symptoms and cognition very similar to schizophrenia. The challenge, of course, has been how you go from that finding to developing compounds or new treatments that can reverse the findings. And I think what you're saying is absolutely true, that at least now we have some drugs coming to clinic that can test these theories that we've been working on for, as you said, over 30 years.
So let's go back to our case study and talk about his current status. In terms of medications, George has transitioned to a second generation long acting injectable. He's now on adjunctive compounds with lower anticholinergic burden. In terms of cognition, his clinician did refer him for testing, and they did find useful information that he had deficits in the ability to match tones, which of course leads to impairments in things like social cognition. He was enrolled in a cognitive remediation program that addressed those basic deficits as well as higher order dysfunction, and he's showing some improvement. And he's showing improvement not only in his cognitive abilities, but also in his overall functional level. In terms of exercises, he does online cognitive exercises several times per week, and he started to incorporate aerobic activity in his daily routine. He feels better, and maybe he's benefiting from that. And in terms of functional status, his family reports that he has improved somewhat. He continues to be followed in a day program, but he is still not returned to school or found employment. So in terms of practical takeaways from this, one, of course, is cognitive impairment is present before the onset of psychosis and affects virtually every patient. It may, in retrospect, occur even in the 3 or 4 years preceding illness onset and may be attributable or may cause a fall-off in academic performance starting even as early as 8th grade and a fall-off between 8th and 11th grade. Cognitive change is evident during the prodrome may be a risk factor for conversion to psychosis, and that's especially important if you see individuals with a family history of schizophrenia. In individuals without a family history, fall-off in things like reading ability, while more common in people who develop schizophrenia, are not common enough that allow you to really suspect that it's from schizophrenia. Only in retrospect you realize. But people that have genetic loading for schizophrenia, if they start developing cognitive changes in the period, say between 8th and 11th grade, it is a cause of concern and should be considered as the possible first sign of the development in schizophrenia. Negative symptoms may be expressive or experiential and may confound the diagnosis of cognitive impairment. Negative symptoms by themselves may affect function. Sedation, extrapyramidal symptoms, anticholinergic effects can contribute to cognitive impairment. Account for this when selecting an antipsychotic and choosing medications for things like extrapyramidal side effects or sleep. And of course, always remember, first do no harm. Make treatments of cognitive impairments a greater focus in your practice. And it's important in multiple ways. It's important to educate families and patients that the expectations that they might have had for academic or vocational achievement before the illness was developed, people might have expected to go to college, might have expected to go to grad school. After the onset of illness, those options are less likely, and people need to make new plans that take into account the cognitive impairments. So even if you can't treat the cognitive impairments, educating about the cognitive impairments is very important. Current approaches to improve cognitive impairments and functioning include cognitive remediation, exercise, and skills training. and these are improving all the time. And at least a person should be given an opportunity to benefit from interventions like this, and should be given thorough cognitive testing so at least clinicians and families and patients can understand the source of the cognitive abilities. There are no approved pharmacological agents for cognitive impairment in schizophrenia at present, but several are being studied, and the next several years will be very informative about whether new treatments can be developed. So with that, I'd just like to stop and thank you very much for your attention, and thank Boehringer Ingelheim providing the grant to support this program. And just to reiterate that cognitive impairments are in fact a core feature of schizophrenia. They're the illness. They're not just a side effect of the symptoms. One needs to acknowledge them as part of the illness, accept them, teach about them, test them, and do whatever one can to treat them, be it cognitive remediation, be it exercise therapy, or be it incorporation of some of these new medications if and when they become available.